silent mode. Thank you. Have we started the recording? Yeah. Apologies for absence. I have apologies from Councillor Richard Dodd and Councillor Rebecca Wilczek, and I don't think there's any others. No. Minutes of the previous meeting. We have the minutes in your papers, the minutes of the meeting held on the 3rd of May and on the 31st of May. Does anybody have any issues? I can't see any, but...
Move acceptance, Chair. I'll move acceptance.
Thank you. Is that seconded?
I'll second it.
Thank you. Disclosure of members' interests. Does anybody have any interest to disclose? We do have a list in front of us of what should be disclosed. Any disclosures? No. Okay, right. Forward plan. We have the forward plan of key decisions from the Cabinet. There aren't any that affect this committee. Any future ones will be reported. Health and Wellbeing Board. You've got there the minutes of the Health and Wellbeing Board held on the 12th of May. They're attached. Any issues on there that you want to comment on or ask for further information on? No? Okay. Reports for consideration by this committee. We've got the report of the Director of Adult Social Care, and we have with us today, so it's been the Extra Care and Supporting Housing Strategy. We're having an update on the strategy for the development of housing schemes that have been approved. We've got with us Alan Curry, who's the Service Manager for Commissioning of Adults, who's going to take us through the report. Thank you, Alan.
Apologies. You can probably tell from that I don't normally come to this committee, so I'm Alan Curry, Commissioner Manager effectively in Neil's team in Adult Social Care, and we've picked up responsibility for trying to drive forward the supported accommodation and extra care developments in Northumberland. We work closely with housing, but quite often we would commission care and support and accommodation at the same time, which is why we've tied those up in adult social care. In terms of the report, so Overview and Scrutiny Committee had asked for an update on how the programme is developing, so I'm here to give an update. The Council adopted a strategy in July 2018, and it's a strategy that sets out plans and the advantages of developing extra care and supported accommodation in Northumberland. And just so you can visualise what I'm talking about when we talk about those kind of schemes, we've got some existing extra care services for older people in Northumberland. So for anybody who knows the Manors in Prudder or Weavers Court in Alnwick, for example, that's the type of extra care service that I'm talking about. For supported accommodation for people with learning disabilities and mental health problems, they're probably less visual schemes, tend to be in mainstream housing developments. Perhaps you might not know most of them are there, or you may be able to spot that we do have small developments in clusters of accommodation, which have mainstream accommodation, bungalows, flats, but care and support attached to them. And we've got a lot of that dotted around the county already. So just to sort of try and help you visualise what we're talking about. In terms of the report, there's a map on page 2 of the report which sets out the developments that we've got in different parts of Northumberland, as you'd expect, where we've got the concentration of people. We tend to have a concentration of services in those areas, but we are attempting to work county-wide with the developments of both extra care and supported accommodation. It does help keep people in their communities, helps keep the people independent, close to families, friends and other amenities that they are familiar with. So wherever we can, we're targeting developments right across Northumberland. In terms of the report on page 3, we've got some data there which tells a story of increasing numbers of older people right across the country, but in Northumberland as well. We haven't seen a corresponding demand in older persons residential care services, despite that increase in the older persons population. And I think that's people voting with their feet, that they want an alternative to older persons residential and nursing care. And certainly we try and support people in their own homes wherever possible, but we also think that this type of accommodation would fill a gap between people living independently in their homes and needing to go into residential care. So that's one of the main motivations really for us adopting the strategy and trying to drive forward that type of accommodation with support attached to it. In terms of where we've got to with developments so far, I think there's a different picture really. I think we have struggled to get some of the extra care older people around. They are more complicated, they are bigger developments, they require more land, and they're far more expensive as developments. So it's fair to say they have been more difficult to get up and running. But we did see this year a fantastic service opening in Cramlington, if anyone knows Roseborough, which was developed by Benicia, opened earlier in the year, and that's a fantastic facility and a good illustration of where we're trying to get to in different parts of Northumberland. It really is a fantastic site. We have had far more success in terms of the specialist supported accommodation. As I say, it tends to be smaller and it is easier to develop. Is my voice carrying above the sound of the drill in there, hopefully? It is easier to develop. Sometimes we can convert existing properties, we can remodel existing accommodation and schemes, which means we don't necessarily have the complication of having to start from scratch and go right through the planning stages and all of the capital that's needed to get those off the ground. So we've been far more successful with that type of development, and you can see we've included some of the numbers there in the report for you to have a look at. We do have quite a few schemes in pipeline, and because of the difficulties that we've had in getting the older person schemes off the ground, we are starting to look at putting capital investment into the developments. We think some of them have slowed down and become a bit stuck because of resources. We know that COVID's definitely had an impact on delaying them, but also when we've come out of the pandemic, we're all experiencing the inflation in different parts, and the building sector is experiencing that as well, and that's certainly meant that some of the developments that we have planned have been held up. Where we can, we will make use of national resource through Homes England and trying to increase capital input into some of the developments via other sources, but if that's not possible, then we've got capital available in adult social care to be able to invest and try and drive some of these forward. Certainly from what we've seen in Cramlington, it's been the service there has been in exceptional high demand when it opened up. So 60 units, they were all snapped up by people incredibly quickly. And when we watch what happens with the Manors and Weavers Court, we can tell that they are still in high demand amongst the public. For us as a service, we do benefit from that type of development as well, because it helps concentrate people together. So where we're struggling with services like domiciliary care, it actually brings a cluster of people together into one location and means that it reduces travel time and certainly reduces the strain on the resource in domiciliary care. So we're very much still committed to the agenda and the programme, and there'll be a refresh of this strategy over the course of this year, and that will be completed by the end of this financial year, so by the 31st of March 2023. But I don't expect there to be anything more than full commitment again to the programme articulated in that refresh of the strategy. Happy to take any questions or clarification points.
Thank you, Alan. And I do apologise for the noise. I've just asked if we can stop it, and apparently we can't. So we'll just battle our way through. Thank you for this. Having watched the Roseborough one step by step, week by week, I am not surprised it's oversubscribed. It is very impressive. Wendy, before we move on, have you got anything you'd like to say?
Just agreeing with you about Roseborough. I actually met Alan on site and we had a good look round, and I thought it was amazing. I mean, and the fact that it's very near to the Meadowhall shopping centre, always get it, Meadowbank.
Wrong city. Wrong county.
But because it's near the shopping centre, it's perfect, really, absolutely perfect. So yeah.
The report is for an update for us, but I'm sure that Alan's happy to take questions or any comments at all. Councillor Hill.
It's just actually a question on a scheme. The old Dove site in Billendean Spittal, it fell through who was going to be the provider. And I know because of the commitment, looking at another provider and doing everything we can. Is there any update you can give just now?
Oops, sorry. We are still keen that it goes ahead, particularly because there's planning consent on that one, so it was really frustrating for it to get as far as it did, for it to come to an end. So I know there are attempts to get capital back involved via Homes England. If that doesn't work, then we're looking at council capital, but we'll have to go through a process if we are to award any provider capital from the council, just to make sure we follow the proper procurement rules. But that's what we're intending to do. We're just taking a bit of legal advice on capital and how we could be able to distribute it. But you know, we're still committed to that one. Still want it to go ahead.
I would just echo, I don't think we can find a better site up in Berwick, to be honest, Councillor Hill, so I think we're really keen for that one to go ahead. It's just getting the optimum funding route for it now. The cost did spiral significantly during the COVID crisis, which is why that developer stepped out at that point. But we'll push hard for that one. Yeah.
Councillor Bowman.
Thank you very much for the report. It's very encouraging, and it would be good to see more due diligence and the action upon that. Can I ask a question about where you identify mental health? Does that include depression?
It could do, yeah. It could include any mental health conditions. I mean, where possible, we would put support into people's existing accommodation. So if somebody lived in their own home and developed a mental health problem, we would try and put support there rather than move somebody. But there are, you know, some people who do need supported accommodation. So round-the-clock staff and other support that comes of being in a specialist scheme. As well, but yeah, it includes learning disabilities and mental health problems predominantly, and that can be depression.
The reason why I mention that, because unfortunately tomorrow I'm attending a funeral of somebody who committed suicide. So it's deep on my heart that our residents are supported by the best means possible. So I'm really encouraged by what I read in this report, and I want you to continue to do so and build on this, so there's less residents losing their lives, and the support is there to assist them through the darkness of the demons that they're dealing with. But thank you.
Councillor Hunter.
Thank you, Chair. Just a comment, as there is 2 or 3 houses within my ward that has 3 or 4 people living together with, and it's nice the fact that you don't notice the difference. They just fit into that community, and I think that's a way forward as well, as that's supported and they're just part of the community, and unless you were looking, you wouldn't know how to identify them as being any different to a resident.
Thank you. Actually, I agree with you, Councillor Hunter. It was really nice to read in the report that the supported part of the housing scheme has been going ahead because it's smaller units that have been able to, and it's really nice to see how well that's progressed. It's the older people's accommodation that's been held back. So I agree with you. Any other questions? No? In that case, Alan and Neil, thank you very much indeed. Are you staying as well? Yeah, okay. Thank you. So move on to the next report, which is improving access project feedback. And Pamela Phelps from the Integrated Care Board is going to take us through this. We had the engagement work was undertaken by the then CCG regarding GP access in Northumberland. So Pamela's going to take us through this. Thank you.
Thank you, Chair, and thank you for the invitation to come back with this report, which I think as a CCG and now into the ICS, the Integrated Care System, we find this to be really valuable, especially with the profile and the focus on access to health services, and more specifically in this case, general practices, because I think this affects all of the communities and how they differ across the county. So, have I got this switched on? Yeah, there we go. So a bit of background as to why we undertook this. I think initially there is a perspective that this was reactive to the COVID pandemic and the reduction in face-to-face appointments. There was media coverage on access to general practice services, and there was a lot of new digital tools introduced, and the ways in which patients access services with their general practice changed quite a bit during the pandemic. And we didn't have a lot of time to understand patients' views on these changes, understand the impact on them and their families, and then not just accessing services, but then the impact on their lives following that. So that was one aspect to this. The other aspect is all of the communication we maintain with elected members as a CCG and an ICS going forward, and the views of the constituents around the county on accessing services as well. So whilst this was focused around the changes in the pandemic, I think they expedited just what we were hearing in general across the county. So we did secure some funding, some service development funding from NHS England to undertake this project as a one-off significant piece. So an overview of the research. We asked Explain Market Research to undertake this for us because we wanted this to be independent. We wanted this to really capture the views from the people on the street, in the communities and in general practices. So what we did was there was over 7,800 surveys completed, which we developed, which was quite extensive. We had to cut the survey down a number of times because whilst it was about experience on services, it was also about understanding people's needs in the future as well. So we wanted it to do a bit of both for us. We had on-street research. There was 504 interviews in local supermarkets and main towns across Northumberland. We had 11 focus groups, which were around children and mothers and children, young people's services. We asked voluntary sector organisations to assist, and we funded them to do some targeted group work. Now, they were spread right across the county again. We had people who had mental health challenges and other voluntary sector organisations to help us, because I think that dynamic of people's needs changes your access, and we wanted to capture that full range. So whilst we've got over 300,000 population in Northumberland, we're talking about, 4,000 people there potentially. It doesn't sound a great proportion, but that is quite a significant response in comparison to other surveys we've done across the CCG in the last number of years. So we've provided you with the full report, but we've also provided you with, in the slides, I just want to go some of the headlines that Explain extracted for us and what they thought they heard, and some other elements. So another tactic we took with this was the changes nationally came in during COVID, and they also impacted the workforce. We wanted to make sure we had a balanced view on this, because the well-being of the workforce and how they've responded to the demands and the change in access that gives a balanced flip side to what patients are experiencing. We wanted to understand the full range of the impact of the access changes to general practice. So this slide here just gives an overview of what we heard from those in-depth interviews with general practice staff. So they did see a significant increase in demand, and we're not really seeing that slow down much. So we need to understand that a little bit better. General practices are under pressure, like the whole health and care system. And is it increased demand, or is it we've still got an impact on the workforce and the staffing levels in our health and care services that is making these pressures and increased demand seem more prevalent? We are having a workforce crisis. For the first time in this last few weeks, I'm having conversations with practices in Northumberland to say they're struggling to recruit GPs. Now, we haven't really faced that problem in Northumberland in the past. So I think some of the benefits of networks, skill mix and other healthcare professionals, which come out as part of the patient user survey results, is really important about how we use and inform and engage and educate going forward. We also faced a lot of change. They talk about too much change, and the NHS is great for change. How we keep up with that, how we implement those changes takes a little bit longer to instill, but we need to remember to bring our populations along with us on this journey. So again, that's just really highlighted to us. So those were some summaries of the staff and their well-being and just the physical working environment. So like you talked about with the estates, from a social care and wellbeing perspective, we've done a lot of work in Northumberland, CCG carrying through to the ICS, how we look at the physical working environment and premises in general practice and health in general. They are some of the elements of change that the practice has highlighted to us. So triage, again, I think it's really well received in practices because they can get the right professional to the patient sooner. But we need to support patients to understand why triage is a benefit to them. And I think that's certainly prevalent in the results of the survey. Returning to normal, in inverted commas, what was normal before COVID. It might be a different normal now, but allowing signpost and use of multidisciplinary professional teams is certainly where we are looking and hoping we can gain some benefit on that workforce pressure. There is mention throughout this presentation and report of AccuRx, which is a tool, and I think tools in general, not just a named tool, is something that came out, but the practices have certainly felt alternative ways of communicating with their patients. They've benefited, and it's just learning now which tools suit which patients and how we tailor those to the needs, because a parent with a young child is very different to someone with a long-term condition, which we all know about in our personal lives, and how we respond to that. So this is about tailoring now what we've got and taking it forward into the future. Education of patients. So I think education's I think it's quite a derogatory word. I think education, I think everyone knows how we use services and the best use of our NHS. I don't doubt that. But I think there's just something about information and being more transparent from practices with the patients about changes, information and opportunities to work together to develop, and patient participation groups will become a strong focus within that across practices and wider primary care networks as groupings of practices. And in the NHS, we are great at terminology that means only something to NHS employees. So we came to the conclusion we need to define the script and really give definitions that mean something to not just healthcare professionals but to patients as well. So we want some help with that from our patients and engagement, and hopefully yourselves as partners in this journey moving forward. So from a patient perspective, we've pulled out some areas. So the overall satisfaction from patients that came out from the survey was, in a score out of 10, we looked at the online and the on-street surveys, and we can see satisfaction has gone down. I don't think it's gone down as much as I'd thought, but then was it at the best level to start with? So I think the baseline has to be taken into consideration here. But it has gone down. pre-COVID lockdown and at present, it has. So we want to build that, and I think the only way we can do that is by fundamentally repairing the relationships between patients and their practices. So that's going to take a bit of work and focus to do. More face-to-face appointments came out, and it's the perception over what is actually on offer. We need to bridge that gap. Improving the phone service, and I'll come on a little bit more about the way practices operate with their telephones and their appointment systems. Being able to book in advance. You don't know when you're not going to be well, but sometimes people need to plan, and I think that's missing a little bit from general practice. Although I understand the reasons why, because of the reactive nature of the change of services, it's kind of gotten lost about that pre-planned and supportive care with pre-bookable appointments. Evenings and weekends, again, there's a national change coming in October, which I think helps us understand patient views on those changes. But evening and weekends have been in place for a number of years in Northumberland. I just don't think patients have been assisted to access it and have been very aware of that. And the morning booking system I mentioned before there. And this is the 8 a.m. rush. Everybody has to set their alarm for 7:30 to get ready to make sure the kids are either fed or they're off to school or you're ready for work, and you can fit in a telephone call to the GP and sit on the telephone in a queue for a while. I can see you all smiling because we've had a lot of conversations about this. Now, not all practices run this system, but we hear a lot about the practices who do run this system. And Kath and I went with a colleague of yours to see a practice in Blythe. And we talked about this because the 8 o'clock call, it does help the practices because they know what workforce they've got that day, they know what they can cope with, and they can manage their system and their services to suit. But that system, I don't feel, works necessarily for patients. Still not working. There's been some changes. So what we did was we talked to the practice to help them understand, what can we do for this patient group? And they were willing to sit and talk with us, listen to ideas, take some opportunities. I rang them recently and I had a conversation with the practice, and they said they are now implementing a book in advance system, so it's not just about all on the day. They are filtering out some of those older, more frail palliative patients who are trying to ring at 8 o'clock. Rather than them ring every day at 8, they're trying to pull them out of the system and get someone to call them back and at least have a contact with them. So I think whilst it's not perfect, because that practice is still under pressure from a workforce and sickness perspective, and they've got a lot of building work going on around them, they are trying. And I think that conversation, that relationship building, just to understand. We were surprised at the DNA rate. They did not attend and they failed to attend. So there's something about a compact with patients about when it's precious and those appointments are a limited number. Patients have a little bit of responsibility to make sure they either cancel it or attend. That's not saying that's an excuse in it at all, but it was a little bit of a quid pro quo in the conversations we had. And the practice was really open to meeting with us again to talk about some opportunities. So that 8 o'clock access model is at the top of our list of something to look at and look at other models around to see why can other practices work without it when some practices think they need to. Another message that came out was the greater availability of pre-bookable appointments. So we presented some scenarios within the street interviews, and we talked about if you have a one-off illness, if you have a long-term condition, or if you're a parent with a child, play these scenarios through. And, families with children, they just wanted to be seen that day. They wanted something to stabilise everything so life could go back to normal and make sure that child was cared for, understood, safe and treated as quickly as possible. With the long-term conditions, it was a bit more, across a week. I think there wasn't much past a week patients would expect to have a response from the practice, and one-off illnesses as well. So as well as understanding their needs, pre-bookable appointments was understood, but only for some certain groups of patients. So again, how do we tailor that? Online booking systems, digital, there was definitely a need. I mean, some patients said they just wouldn't use it. Those patients who, there was a mix on this, and it was quite surprising, the mix. There was a lot of people liked the online and the digital solutions because it meant they didn't have to leave their desk at work. They could get a message and get a response via their phone or laptops or whatever. But there were groups, so those in the socioeconomic groups that we see in the more deprived areas, lower income, and those over 65, there was a need to reaccommodate and rethink how digital options played into the system. The younger, the families and working age adults preferred it. But there was something about raising awareness and how best to use it and how to use it came out of the survey. Face-to-face versus telephone appointments, again, we saw a good mix in this, which was surprising for us. So those who had experienced the telephone or the video versus face-to-face, they were satisfied. But again, it was 50-50, 70-30. I think we just need to understand what that variation mix is and how we tailor. What came out was patients with long-term conditions who liked continuity of care, who knew the GP and had a relationship and relied on that relationship to keep them well. Those were the ones that needed access through the telephone, face-to-face, direct. There was a mix of other groups, but the long-term condition patients and the frail elderly and palliative, obviously, we need to think differently about them and not one size fits all. So we also asked about if the awareness of multiple healthcare professionals working in general practice. So general practice isn't the older model, the original model where it was GPs and practice nurses. They have expanded the primary healthcare team, and that's where I think terminology comes in as well, because we still call it GP practices, and it's a primary care team. So there are physios working in all of our practices now. There's mental health professionals working as part of the primary care teams, pharmacists, social prescribing link workers, care planners who support the health and wellbeing, access to social care and voluntary sector services, social environment, and it's understanding their roles. And at the end of the presentation, I have shared some snippets we've started to develop on the different healthcare professionals and what they can do for patients. And I think there's a big campaign that we really need to promote with that one. And again, what types of illness would you be willing to see different professionals for, and the confidence in those professionals when they did see them. So that all came out of the survey as well. There was confidence in GPs and nurses, but not so much in the other groups, and that might just be an awareness. There was a strong support for out of hours in the evening and weekend. So I mentioned earlier, there's a contract change. So networks and practices have both been providing some extended hours and extended access across Northumberland. I don't think that's been routinely offered when someone rings as an alternative to a Friday morning or a Monday afternoon or whichever. So again, we're working with the practices to really make sure they build in that open, transparent offer of you can come on a Saturday to be seen as an alternative. Might take some of the pressure off during the week. But there was still a requirement for access to some services in the weekends and evenings. There was a low awareness of hubs. Again, I think this is terminology. We know practices are working together in networks. We know they're expanding some of the service they deliver. So this is just about co-delivery across practices. And people were willing to travel. We did get an indication as to the different groups of people who would be willing to jump in a car, take the child from Ponteland to Cramlington, for example, on a Saturday. So again, that was extracting all of that from the results. So there's some snippets of information. What I wanted to do was just give you some examples before I move on to say what we're planning to do and how we're planning to do it. So I mentioned Railway Medical Group with Blythe that Kath and I went to see. Now they had over 1,000 calls last Monday into their telephone system. They provided way over 400 appointments on the Monday. They do have challenging, like all practices do, with workforce and sickness and recruitment. But like I say, they are starting to adapt their access model, which is what we want to see. We want to see people thinking a bit differently, listening to this survey, which we've shared with the practices, and the increased ability to pre-book. I've also spoken to Seaton Park in Ashington recently. I don't know if I've got any members from that part of the patch, but they've also gone through a long period of trying to understand the demand. Patients, pitching to one spec because it's close and they get a quicker reaction to their healthcare needs. They've gone through a massive skill mix. They've employed, they've rejigged their team and their systems multiple times, and they just can't figure out how they keep up with the pace of demand. So they've just, we've awarded them some funding, and they've implemented a new system which supports both patients wanting to ring in, but also patients who like the digital model. And it helps them move away from that ring on the 8 o'clock. You can get an appointment, whatever time of day you contact, there is the ability to still book in or speak to someone and be triaged. They've done a massive amount of work of engagement. I know Ian Lavery MP has been down to see, and I think some other elected members have been invited to the practice. And I would just encourage you, if you want to, let me know, and we'll have a look at that. But we want to learn from that model, so we're supporting them just to capture how that's evolving and what the outcomes and outputs are. And like I mentioned, from October, a contract change means all primary care networks and practices will be asked to deliver services on top of their core from 6:30 p.m. till 8 p.m. Monday to Friday and 9 till 5 on a Saturday. They are the core minimum requirements. However, the national contract change has removed the need to be open on a Sunday and a bank holiday. And as commissioners, we just don't understand why that would be the case. And if practices aren't contract to do it, I can't imagine going to go that extra mile and do something. But again, it's about speaking to patients, understanding need, and designing the services for need, not just what they're contracted to do. So next steps, provided a summary slide there about what do we need to do. And I think there's a lot we need to do, but I think first of all, we just need to consolidate what we've understood from that survey. Now, we can do that as a group of commissioners, but I think we might, be biased. We might see one side of that. We want to develop an oversight group, and we would like members of this committee to join us on that oversight group to understand what we've heard from the survey, but then develop some operational groups to implement change. So that's an invitation to join us and set up that group. I think we need to understand the different models of access out there in practices and how we can talk to practices through the groups to come up with some alternative solutions. We've had some practice managers working with us on the survey, and it's been really useful from their dynamic. Healthwatch have been involved, and I know Derry apologised for her attendance today. She couldn't attend, but she has shared her comments from this feedback as well. So I think throughout the summer and the autumn, we've got a lot of work to do to set up some groups, understand the next steps. I've mentioned about language, defining the language, further engagement with patients to help understand systems. I think building relationships between patients and their practices needs to become a focus. And I would encourage elected members also to build relationships with the practices locally, and we'll facilitate that. That's basically the summary I want to share with you today. And they're just some snippets of information about the primary healthcare team that we plan to use in the future. Thank you, Chair.
Thank you. I'm sure people have got comments and questions. But first of all, you've just mentioned that Derry isn't able to be with us today. She has sent in some notes, which I think you may have seen. Chris is going to circulate them round to the members. But there's a few things on there that I thought we should highlight. So if you don't mind, I'll just do those before we do anything else. The Health Watch report says is that, and I know we've discussed this one anyway, but much of the findings on patient satisfaction mirror what they've heard and continue to hear about GP access. That morning rush to get an appointment, being unable to get through, and then when you do, there's no availability left. And the inability to book routine appointments. So I think that's clearly one of their main issues they've picked up. They also had 2 questions. So one thing that doesn't seem to be mentioned is further awareness raising about e-consult. It says pretty much everyone they speak to who complains about inability to get an appointment hasn't heard of e-consult. So what can be done about that? And the second question is the face-to-face versus telephone. In your report, you mentioned the need for segmented approach, but not much information on what that actually means. Could you clarify it?
Okay, so e-consult is one of the tools, and I think this is something we really want to focus on, about how we inform patients and the public around what tools are available and how they can use them, when best to use them in different scenarios. So I think through the groups and with the assistance, you know, of patients and lay members, it would be useful that you help us along with that, because, as I say, we could come up with solutions, but it might not be the best outcomes. So I think e-consult is, from a personal perspective, it's easy to pick up my phone, I can go on the practice website, I can put in all the information, tell the GP what I'm you know, in contact for, and you get a text straight back. And they'll say, we want to see you, or speak to the pharmacist, or do. So it's a non-contact communication, but there's multiple tools out there. They all don't use e-consult. So I think there's something about digital tools and supporting the use of them, and not just awareness of them. And then the second question was around the segmentation. So I think that's what I mentioned earlier around the tailoring and understanding the access models that different patients, such as people with long-term conditions, need to have a more tailored approach to access than maybe children and parents with children, or working adults, or others. But as I said, Derry has been part of the working group up to this point, and again, we hope to continue the Health Watch input moving forward.
Councillor Hill.
Thank you. Now, obviously in this report, there's things about highlighting this new e-consult service, so I don't know how new it is, but highlighting it, and about using pharmacists. I think it's important. Pharmacists are a very useful resource to use, but the problem is when you speak to residents they're almost, which is worrying, not even angry anymore. There's a sort of weary resignation. You know, people will say, you can't get a GP. You know, that's the attitude now, which is really worrying. And with all the goodwill and with this report, I don't think this process is going to change anything, because there's such a fundamental problem here. I mean, one of the fundamental problems is GPs used to see almost like, you know, religious people, even sometimes politicians or other lines, as a vocation. They didn't care, or working all hours God sends. They see it now, we've got right to finish at 5 o'clock and weekends, and because there's a shortage of GPs, they get paid better so they can retire early. So I don't know what the answer is, but I just see, when I see a report like this and a process defining in a structured way what everyone knows, it's not the radical thinking that needs to happen, and this needs to happen nationwide, because it's a serious problem and we're so used to it. But when you think about it, you think, why is this a acceptable situation which is risking lives because people are now, you can't get a GP support? Simple as.
No, thank you, and thank you for your observations, because I think you're right. This is one dynamic of it. And a patient experience is something that we are, you know, conscious of, that we hadn't done. But I think you're right. It is only one dynamic of this, and it is a national challenge. You you know, that we're muting about the partnership model in practices. So I think salaried GPs, and we do have a number of salaried GPs around the county, their requirements, you know, do change, and the contract allows them to finish at 5 and have a shorter day, which is a better quality of life. We have a lot of partnership models in general practice, and that isn't the experience of a partnership. So we're seeing less and less GPs committing to those longer days, weekends, the challenges of running a practice, and that is a national dynamic that is changing. And the workforce, you know, talking about pharmacists, if we don't have GPs, we need to bolster up a primary healthcare team. So those prescriptions can, and managing prescriptions, managing medicines doesn't need to be a GP conversation. And the precious time we do have for GPs is kept for those more in-depth medical conversations. I think the offer of general practice, they have tweaked it, you know, quite a lot with, we've got GP fellows, which is people straight out of the training, qualified GPs. It's another 18-month programme, and it gives them support whilst they're in general practice. We're looking at retention programmes to keep GPs at the other end and the wellbeing safe. I think it is a much wider problem, and I don't think in any way, shape or form we see this as the only solution and the only way forward. It has to be multidimensional.
Thank you. Councillor Hunter.
Thank you, Chair. A couple of issues is we've got the older population that is used to the face-to-face consultations. They're maybe not so much for the e-consultations or the phone consultations, and as well as the disability, because there's different forms of disability that they can't use this. So I think we need to look at that, because we're picking up the factors. They like that face-to-face, where the younger generation probably likes the e-consult and the telephone because they can work and that. As well as I'm hearing a lot of people not getting called back for like blood checks and reviews for diabetics and that. Sometimes they're 2 or 3 years down the line and they've not been called back. And if they've had an operation, say a heart operation, they've been put on medication, they're not sure whether it's working. And I think these sort of things seems to be slipping through the net. And I think they need to be looked at as well.
No, I think it's really useful that you're sharing this information with us. And again, these are the conversations we are having with practices about how they prioritise. So we've come out of COVID. Yes, they prioritised. Getting back to normal is the perception that everyone's back to normal, but there's still a lot of sickness and workforce issues. I think what you're describing is those people with long-term conditions, they are still a priority, and we need to ensure that they are and remain a priority for practices. But yeah, it is one of the challenges, and I just take on board your comments, and yeah, thank you.
Councillor Nesbitt.
I'm just, sorry. It's just really about the retention of GPs. I'm pleased you said that, because I think we do need to make sure we're keeping the GPs in the practices because of the problems we have. But on the other hand, I believe our problem really started the amalgamation of the Waterloo and the Railway Medical School. When you're looking at how many patients that's on the list, over 30,000 now on Railway, is a lot of patients, and they can't manage that at all. Mm-hmm. And I think that's the biggest problem going on there. I mean, we did go and see them, and I come away feeling a bit agitated still because of the way that went on. But I would like to see the retention of the GPs, and we still need a long way to go with our practice in particular. No.
Yeah. So I'm happy to work on you on that with you and have other conversations. But I think you're right. Mm-hmm. The mergers of a number of practices in Northumberland created much bigger practices, and I think size isn't always the answer. What we are seeing now is alternative models. So you may be aware of a number of practices in the north of the patch have kept their contracts separate, but they're still working together. So they haven't created a big practice with a big list. No. They've kept this number of practices, but they've created a different level of support around. And I think these are the examples we're starting to see evolve, and we're trying to encourage with practices who are facing, challenges that give them a more of a chance, that where they're not absorbed into size. I'm not saying size doesn't work for all, because it has worked for some, but I think we need alternative models of general practice to keep them sustainable into the longer term. So we are starting to see some different models starting to appear, which is good.
Thank you. Councillor Bowman.
Thank you, Chair. Just recognise today is the 74th anniversary of the founding of the NHS, and it's a wonderful organisation that saved many lives and improved the lives of many people in the United Kingdom. After saying that, I recognise before COVID that our A&E was jam-packed with people trying to access a doctor for minor ailments and that sort of thing. I don't know if that's come back again or if it's actually moved on to the GPs direct. Can I make a comment about e-consult? I do have a concern. I understand it, and I've used it actually. I understand its principles and I understand why it's quite useful. But isn't there a case where a patient goes into the doctor and explains a minor symptom of whatever, and it turns out to be, at the end of the day, a life-threatening condition? There I do have a concern. On e-consult, could that be missed? If it was done face-to-face, as the patient is walking to the door, a bit like Columbo, as the patient is walking to the door, the doctor asks one final question, and that final question is related to that person's longevity. And it is that face-to-face. I believe that sometimes GPs can sense something that's wrong with a person when they're speaking to them face-to-face. And I don't want to see that disappear. I want to see that enhanced, actually. Fair enough, if you've got a minor ailment, we can use e-consult. But are we not missing something here? A one-to-one, is it not more personal, more direct, and a bit more intimate, where it can? And it has. It actually saved my life. It can save lives. Thank you.
I absolutely agree with you. I think face-to-face and the relationship between patients and GPs, I think although the challenges of the workforce and the more demand, there's just not enough appointments to give everybody that face-to-face. But you're right, we have to find the safe mix between how we use tools to have a first contact with a patient and a healthcare professional, and rely on the fact that those face-to-face will occur after that first contact, which is why we need to build the confidence. But we need medics, and normally I would have a medic sitting right next to me here, and I don't today. I would normally have a GP with me who could answer that from the horse's mouth. But I think all of this confidence or lack of confidence in these tools is why we need to focus on them and build either a confidence or make a decision where do they have a place in Northumberland, and do they have a place? The issue is they've been tied to the GP contract that they must have them, and that's what we're trying to translate in Northumberland about where they fit. So if it's a national requirement to have a digital tool, how do we translate that to make it work for patients and the practices, locally? And which is what we're willing to work on with a number of people.
Thank you. And thank you, Councillor Bowman. That was going to be my question, so thank you for asking it. Councillor Hardy, and I think that's probably the last question, right?
Yes, hello. I sit as chair of Wellclose Square Medical PPG, and as we come out of COVID, it's a change in dynamic. It's a completely different picture to when we went in. And yes, there are difficulties about staff retention, but the services that are provided are excellent services. But it's the lack of dissemination of what is available to patients that appear to create a problem in itself. And I don't think that we're getting enough information out there to the general public There's changes with like the Lindisfarne Medical Group, there's changes with Well Up North. There's lots of diverse ideas going on within the medical practices, but we are not getting that out. Do you see that as something that needs to be addressed?
I think anyone that comes to us who is aware of changes and doesn't feel they're fully informed, I think as a commissioning organisation, I will say CCG, we're not a CCG anymore on Friday. As a commissioning organisation, I think I would support you to and help facilitate how we can get some of that information. We've looked at PPGs and I just don't think they are being as effective as they could be. So we've talked with the network leads and GPs around how PPGs could have a more substantial role. But I think it's that transparency of information that just helps the role and what the PPGs, such as yours, because not all of them are as strong or as motivated as the others. So I think I'm quite willing to work with you. And I think if we could have a conversation, we could see what we could do about that, Lindisfarne, Well Up North, engagement. But it is on another to-do list that we have, that PPGs and how we expand them and better use them. But I think what you've specifically mentioned is just about lack of information. So if we can facilitate that understanding of what is going on, what it means, and how you then support patients, the wider patient group to understand it, we'll certainly look forward to working with you to do that via the PPG.
Thank you, Pamela, and thank you because we've asked a lot of questions. So thanks for sitting there. You mentioned setting up a group, and I think if Chris could contact members to set that up. Yeah, is that okay? Work with you. Okay, and thank you very much. Thanks for doing that, and thank you for sitting there and answering all our questions. Thanks. The Health and Wellbeing Work Programme is next. You've got the report in front of you. I think it's fairly self-explanatory. We've discussed it before. Are there any other items that you think we should particularly be looking at putting on the programme? And perhaps if you think of any, you'll talk to myself or Chris about it.
Sorry, the one thing I did want to say is Northumbria Healthcare have agreed to come and talk to us about their social care plans. They were due to come in March, I think, and they withdrew at the last moment, but they've agreed to come back in October to deliver that presentation. That was the only thing I wanted to mention.
Thank you. There's no urgent business, so our next meeting will be the 6th of September. I'm going to stop the recording now. I say thank you very much.